at setting up for cervical traction. So because the traction device doesn't move, we're actually going to change the patient position. So the patient's head will go up closer to the traction device. This is a unit that connects and anchors directly to the DTS head itself. So this device does not move, and what we're going to do is we're going to attach the patient's head to the slider, and we're going to pull on the slider. A couple things to take into consideration. One is that these pivots, so they will move with the size of the patient as well as our ability to clasp down. We're trying just to grab the base of the occiput behind the mastoid process. When you touch the material, you'll also feel that it is a non-skid material. So again, we're not concerned with squeezing the head so tight that, that we're cutting off any circulation or creating any discomfort. As long as the patient is free of perspiration, then it'll decrease any opportunity for it to slide through there. The way that they're shaped also cradles the base of the occiput, so it minimizes any excess movement. We also have a forehead strap here that's going to go across the cranium, and again, that's just to make sure that we keep people in a down position, so it doesn't have to be excessively tight, so we don't have to worry about putting it on so tight that it pulls their neck into extension. We just want to make sure that they can't move from that position. So we get people into the position of the device. We have them sit again where the pelvic pieces will be, and we lower them down. So we want to get this at the base of the occiput. Patients that have long hair, make sure they put it up into a ponytail or something where it's tied back. We don't want excess hair coming out to the side. These spin dials here, we want to make sure that we can't catch hair inside of those spin dials, and so we'll just have the patient come over and sit on the device facing us here, and we'll have them rotate around. And again, if you need to assist the patient, so again, patients with long hair, make sure that the hair is back and away from the turn dials. We explain to patients that we're just looking for enough tension to grab the base of the occiput with these non-skid devices, and we're not trying to over squeeze their heads. And as we turn the device, it will equally clamp from both sides. How's that? Good. Again, patient comfort is important, so we're always asking patients how they feel when they are strapped into the device. The clinical protocol determinations are very similar to that of lumbar traction. So we keystroke in, we can save protocols, we can retrieve protocols in the same manner that we did that with the lumbar traction. The difference when we attach the device for traction in the cervical spine is, again, we're actually going to attach it to the device itself. And so the whole apparatus is actually going to slide on this sled piece here. Now, when we're looking at the angle, as you can see here, they're actually at a neutral angle. The way that we can change the angle is by changing this pad here. We measure the angle based on not the guide here, but relative to the torso. Similar in the clinic setting, when we want to measure cervical angle, we use a goniometer and we'll measure relative to the torso. So what we can do is, by increasing the angle, I will just simply drop the table down. And what that does is that puts her into a more flexed position and reducing the lordosis. And again, if that was a protocol determination where we wanted to increase that flexion moment, that increases the depth of the angle where we're going to address most of the tension. So at that particular angle, we'd be at about C6, C7. And if we wanted to go back up to neutral, we simply raise the table back up to neutral, and that would address the higher segments of the cervical spine.